For any therapist or doctor or physician, it is very important to be able to diagnose the patient. And whenever we talk about diagnosing a patient, it all starts off with the observation, inspection, and palpation. And these three skills are very integral and important for any practitioner. To be able to understand the structures and to palpate, observe, or inspect them, one should have a good knowledge regarding the superficial anatomy and orientation of those structures. And that's what this section in the scapular region and superficial back is concerned about. And in this section, we're going to talk about the triangle of auscultation, the orientation of the articulating surfaces, and the spinal contribution to shoulder motion other than the superficial anatomy as well. So, taking at this picture, let's take a look at some of the major structures that we can just observe or we can inspect superficially. So here we can see the first most prominent vertebra here is actually the spinous process of the seventh cervical vertebra, and that is the most prominent vertebra when you are palpating or any structure in the back or different vertebrae. And that actually gives you the information regarding your assessment. For example, where would be the first thoracic, second thoracic, or sixth cervical, or any vertebra that you actually wish to palpate. So you can use the seventh cervical vertebra as the reference point. Another important thing that we can see here is the trapezius muscle, which is like if we join the left and right trapezius, it looks like a quadrilateral. And we talk about the individual triceps, it looks somewhat like a triangle. So it has the upper fibers, the middle fibers, and the lower fibers. So here you can see these fibers which are actually coming from here are actually the superior part of the trapezius or the upper fibers of the trapezius, sometimes also known as the descending part of the trapezius. Here in the center is the middle trapezius or the transverse part of the trapezius. And here we have the lower trapezius, or we sometimes also refer to as the ascending or the inferior part of the trapezius. So we have talked about the seventh cervical vertebra, the trapezius, and then coming more laterally, we can see the medial border of the scapula here. We'd also call it as the ventral or the medial border of the scapula, the medial border of the scapula, or sometimes also called as the vertebral border of the scapula. So even though in this picture we can see that there's a lot of distance between the spine and the medial border of the scapula, because the scapula are slightly protracted, but otherwise the distance is up around 3 inches in width between the vertebral border and the spine of the individual. Moreover, another important structure is the posterior axillary fold, which is you can see here, and similarly there's an anterior axillary fold which is formed by the pectoralis major. Here we can see this is the teres minor, and here we have the rhomboids, and this muscle, which is very important and a part of it is actually masked by the trapezius, is the latissimus dorsi. And here we can see the posterior aspect of the deltoid. Here we have the middle aspect of the deltoid, and on the anterior or the ventral aspect we have the anterior aspect of the deltoid. And here we can see, due to the prominent bulk of the erector spinae, we see that there is actually depression in the center of the lower back. So that was the superficial, and if we take off the skin and the subcutaneous tissue, then we can look at these muscles. So this was actually the trapezius, and this is the upper fibers, the middle fibers, and the lower fibers. On the lateral to the trapezius, we have the deltoid, which is an important muscle of the scapula as well as the glenohumeral joint. And here we have the latissimus dorsi. The trapezius covers the little part of the superior aspect of the latissimus dorsi and also the rhomboid major. Here on the right side, where the trapezius is removed, we can clearly see the rhomboid major and just above the rhomboid minor. Here we have the levator scapula, which is connecting the superior medial aspect of the scapula with the transverse process of the cervical spine and responsible for the elevation of the scapula. You can also see the supraspinous muscle, the infraspinous muscle, the teres-minor muscle, and on the ventral aspect, we can also look at the subscapularis. So the superior border of the latissimus dorsi and a part of the rhomboid major, as I already mentioned, are actually overlapped by the trapezius, as you can see here, and even the major part of the rhomboid major is actually hidden beneath the trapezius. The triangle of auscultation or auscultatory triangle is actually a very important structure talking about the superficial anatomy, because triangle of auscultation is actually formed by the superior border of the latissimus dorsi. So here we have the latissimus dorsi, and this actually is the superior border of the latissimus dorsi. Then we have the medial border of the scapula or the vertebral border of the scapula, as you can see here. And then we have the inferior lateral border of the trapezius, which is here. If we look at all these three structures, the latissimus dorsi, the scapula, and the lower trapezius, then we have a small gap in between them, and this small gap is known as triangle of auscultation or auscultatory triangle. Now, what is the clinical significance of this auscultatory triangle? The clinical significance is that it is actually an area, an opening, which provides a place to examine posterior segments of the lungs via a stethoscope. And if we wish to enlarge this area, then we can enlarge it by asking the patient or the person to fold their arms, which results in the scapular protraction. And that scapular protraction actually increases the size of this auscultatory triangle, and it makes it easier for the physician or practitioner to actually auscultate in the triangle of auscultation. Now, talking about the surface landmarks, we need to understand where the scapula actually lies. So when we talk about the scapula, so in the resting position, it lies between the second and the seventh rib on the thorax or the rib cage. Moreover, the vertebral border or the medial border is approximately 2 to 3 inches lateral from the spinous process, as I already mentioned in a picture shown previously. And if it is greater than that, then it means that there is you can say protraction of the scapula, which has increased the distance between the vertebral border and the vertebra or the spine. Moreover, the spine of the scapula, the structure as shown here, this one, the spine of the scapula is approximately at level with the spinous process of third and fourth thoracic vertebra. There can be a change, third or fourth. So here we can see, so this is, here we can see the trapezius very clearly. This is the trapezius, lower fibers, middle fibers, upper fibers, C7 most prominent segment, T1 and T2 to T7, where actually which corresponds with the presence of the scapula in the neutral position. T3 actually corresponds with the spine of the scapula, and you can also see the deltoid muscle here. And this is actually the posterior median furrow, which I was talking about. Because of the greater bulk of the erector spinae on both sides, this furrow is actually created. And here we can see this is actually the superior aspect or the superior border of the latissimus dorsi, and this is actually the lateral border of the trapezius or the inferior trapezius, which actually slightly overlaps the superior border of the trapezius and also hides the major rhomboid major. Now, axillary fold, as we already mentioned in the previous picture, so this is the posterior axillary fold and this is the anterior axillary fold. This one is the axillary fossa, and anterior axillary fold, posterior axillary fold. The anterior axillary fold is actually formed by the pectoralis major, whereas the posterior axillary fold is formed by the teres major and the tendon of the latissimus dorsi. Now, teres major muscle can also be observed or palpated in the posterior aspect or the dorsal aspect of the upper back or the scapular region. So teres major forms a raised oval area on the inferior lateral third. This is the inferior lateral third, inferior and the lateral aspect of the scapula, when the arm is in adducted position and it is further adducted against resistance. So this is the teres major muscle here. So if the patient is asked to adduct against resistance, then that would actually result in the increased bulk or tone of this muscle, and that can be easily palpated. Now, talking about the orientation of the glenohumeral articular surfaces. So one is actually the humeral head, and one is actually the glenoid fossa or the glenoid cavity found by the scapula. So talking about the humeral head, it is retroverted 30 degrees and it is uh, inclined upwards. So there's an upward inclination and there is a medial inclination of around 45 degrees. So humerus configuration is upward, forward, and medial. On the other hand, if we talk about the proximal humerus, so proximal humerus articulates with the glenoid fossa, which is retroverted, which is rotated posteriorly around 7 degrees, and it is also inclined superiorly, which is 5 degrees. So both are superiorly inclined, but the humerus is anteriorly inclined, whereas the glenoid cavity is posteriorly inclined. So this superior inclination of the you can say the glenoid cavity provides a significant greater degree of geometric stability, especially in terms of inferior dislocation. Now talking about scapulo-thoracic articulation, the scapula is actually placed, which is having the concave ventral aspect, is actually placed on the thorax or the rib cage, which is actually convex posteriorly. And for that reason, it is actually anteriorly tipped around 30 degrees in the neutral position. So scapula is not straight like this, it's actually anteriorly tipped because of the convex surface of the rib cage or the thorax. Moreover, it is kept in place by the subscapularis and stratus inferior, and the weakness of the stratus inferior can actually result in winging of the scapula. One more important thing to understand is that it is not an anatomical joint. Scapulo-thoracic articulation is actually a functional joint. However, the movements are there. The movements at the scapulo-thoracic articulation are possible, which we are going to explore in the upcoming sections. So the spinal contribution to shoulder motion, because shoulder or the glenohumeral joint is associated with the movements of the scapula, and the scapula actually articulates over the thorax or the rib cage, which is joined with the spine. So there's actually an indirect association. So the motion of the thoracic and the lumbar spine result in the enhancement of the overall motion and function of the shoulder complex. Moreover, the flexion of the spine away from an extremity during the elevation process further enhances the range of the motion attainable at the glenohumeral joint, and sometimes with limited range of motion at the glenohumeral joint, such as an adhesive capsulitis or frozen shoulder, the patient can still do overhead activities because of the side bending or lateral flexion of the spine away from the side which on which there is a shoulder abduction or elevation that is occurring. Now, spinal motion in overhead activities is actually sometimes required, necessary, and for that it is very important that the mobility of the thoracic spine and the cervical spine is ideal, and that occurs usually in throwing and racket sports such as badminton, tennis, etc. So that was all about the surface anatomy and orientation of the structures found in the scapular region and superficial back. I hope you learned something new out of it. So stay tuned to sqadia.com for more lectures like this. Thank you very much.